ممكن اشير سكرين؟
اعمل الاونج للشير سكرين للدكتور سامي يا دكتور رافي.
تمام يا فندم. حضرتك عملت شير سكرين من عند حضرتك؟
انا عملت اهو. كل واحد شايف السكرين؟
ايوه
يس.
فندم. تمام.
Yes.
ماكسمايز بقى دكتور سامي بعد اذنك.
اوكي بيرفكت.
اوكي.
دكتور سعيد، نبتدي بس نقدم الدكتور سامي. اتفضل يا دكتور سعيد.
ماشي، شكرا يا دكتور مجدي.
ابدا تسجيل الاول، ثواني.
اوكي. بسم الله الرحمن الرحيم. It's great honor to me to introduce my dear brother and dear friend, Professor Sami Metias. Professor Sami Metias is an MD, qualified MSc, FACR, FACB, and he is a board certified in internal medicine and rheumatology, and has master degree in orthopedic surgery from Manufaa University, Egypt. He has a private rheumatology practice in Covina, California. He is a clinical assistant professor of rheumatology at the University of Southern California, president of California Rheumatology Alliance, and past president of Southern California Rheumatology Society. Professor Metias has multiple publications in very reputable and very prestigious peer review journals. He had presented multiple abstracts in the American College of Rheumatology meetings, as well as the European Congress of Rheumatology. Dr. Metias is a member of the editorial board of the current Rheumatology Reviews Journal. And in the meantime, Dr. Metias is a fellow of American College of Rheumatology, ECR, and the American College of Medicine. He also served as the chairman, treasurer, and the president of Southern California Rheumatology Society for 6 consecutive years. He received multiple honorable awards, including Covina City Mayor Award, recognition for organizing health fair to help our community, and sober doctor, top doctor by the Los Angeles magazine from 2016 until present, and the medical honorary award at the Los Angeles Arthritis Walk 2016. He also received Top Doctor Club Member Award in 2014, and he was the recipient of the award Distinction Leadership by Citrus Valley Health Partners. He was also the recipient of the United States House Representative Certificates of Congressional Recognition, as well as the California State Senate Certificate. Professor Metias also assembles the Metias Hope team, currently named the Covina Arthritis Clinical Team, as the foundation for the Los Angeles Arthritis Walk, which is a part of Southern California Arthritis Foundation. He is a board member of multiple charity organizations that support the needy in different countries, and especially in Egypt too. He is a regular guest speaker on multiple TV talk shows, which are broadcasted nationally and internationally about different rheumatological diseases. Once again, it's a great honor to me to introduce my brother, my dear friend, Professor Sami Metias, to give his very fruitful and valuable lecture regarding the small vessel vasculitis. Please, Professor Metias.
Thank you very much. Thank you for this great introduction, and thank you. It's a big thing, you know, I don't deserve all this, but thank you. And thank you for Dr. Saeed, my friend and my brother, and also my senior. He's my senior fellow, which I learned from him a lot. And also I'm between my professors in Egypt, and I respect and we love everyone there in Egypt. So thank you. Today we'll talk about the update in small vessel vasculitis and kidney diseases. So talking about small vessel vasculitis, there is 2 categories. The first category called immune complex mediated disease and pussy-immune ANCA vasculitis, which we're going to be focusing on ANCA vasculitis, and at the end, if we have time, cryoglobulinemia. vasculitis. But generally immune mediated, we have multiple reasons for that. Medications, some medicine can cause that. Antibiotic, NSAIDs, hydralazine, minocycline, propylthiouracil, TNF inhibitor. I saw patients with propylthiouracil for hyperthyroidism, which was complete vasculitis, and sometimes spare the kidneys. And we see TNF. I have publication before an ACR, American College of Rheumatology, abstract about TNF-induced vasculitis, and that's this kind of things, which is Remicade, Enbrel, Humira, these things. IgA vasculitis, it's common, you know that a lot. Cryoglobulinemia, we'll talk about detail later on. Urticarial vasculitis is kind of when you have an urticaria and stayed for longer time, more than 24 days, 3 days, for example, and then you do biopsy, you find vasculitis and can leave scar tissue or leave pigmentation. You have to take a biopsy and it ends up to be urticarial vasculitis, and they treat it like vasculitis. Infection can be part of vasculitis. I remember when I was a fellow, we have a patient typical P-ANCA positive and all these things, and CNS vasculitis typical. We gonna give Cytoxin. My attending said, "Hope stop here. We're gonna do biopsy of the epidural on in the brain and dural of the brain." I said, "Why?" He said, "Yeah, we have and end up to be TB causing vasculitis, CNS vasculitis." So infection can be mimic vasculitis big. All autoimmune rheumatoid, lupus, Sjogren can cause vasculitis, and that's sometimes secondary to that, and we could talk about mainly in cryoglobulinemic also. GPMD, like glomerular basement membrane disease, considered immune complex mediated vasculitis. We're going to be focusing on POSI immune, which is ANCA vasculitis more. GPA, Wagner's, used to call Wagner's, now we call it granulomatous cholangitis. The reason they found that later on that Wagner's is Nazi, and those are Jewish, actually now big against it. So we cannot even say Wagner's here anymore, because and we have sometimes lectures listening how he was Nazi guy and one of the army in the German army. And so we change it to GPA, but MPA, microscopic cholangitis, or EGPA, which is used to call Scherge-Strauss, but eosinophilia with cholangitis, which we have new medications approved for that, but it's out of our area. So talking about ANCA-associated vasculitis, it's rare, but actually it comes in bouts. We find out all of a sudden, few cases comes all of a sudden, 2-3 cases, but it's not that common. And vasculitis generally divided into parts according to the vessels involved. We have large vessel vasculitis, which is like Takayasu in younger age, below age 40. We see it in Japanese, even sometimes ethnic group Hispanic sometimes. And this, so for younger age, when we have different in blood pressure from right side and left side, or pulse different, we have think about it. Or older age, we have what we call it temporal arthritis. That's one, and it's not involving kidney here, but this is kind of large vessels. Then we have medium vessel vasculitis, polyarthritis nodosa, PAN, and PAN can involve also the kidneys, but it's basically PAN is different aneurysm formation, and they have more constitutional symptoms. Fever, weight loss, hypertension, stuff like that, that makes you think about this kind of medium vessel vasculitis. Then we have the immune complex ANCA vasculitis. We have the anti-GPM in the small vessels, and then we have the ANCA, what we call it, this is what we see, small vessel vasculitis, and Wagner's can be involved a little bit medium size. So basically the GPA, which is a Wagner's, necrotizing granulomatous inflammations. There is necrosis in the upper and lower respiratory tract. So it affects also upper, which is sinusitis, otitis media, even trachea, and then lower is lung, and then necrotizing vasculitis in the small vessels, sometimes medium vessels, and necrotizing glomerulonephritis, which we call POSI immune or crycentric glomerulonephritis, and the ocular, even the eye vasculitis, pulmonary capillary, cavitary lesion, big cavities with hemorrhage. And what we worry about is pulmonary hemorrhage. People die from pulmonary hemorrhage. The MPA is basically necrotizing vasculitis, predominantly small vessels. And it is basically, we see more, it's lung and kidney involvement. We don't see a lot of sinus and upper respiratory tract. Pulmonary capillary, commonly involved, and kidney also and skin can be involved. So that's generally about it. But when we look to this picture, for example, we have this purpuric rash. When this kind of purpuric lower extremity rash, if you do like biopsy, it was like leukocytoclastic vasculitis. And this rash is improved actually when you treat patients. And that's kind of, when you put your finger on it, it's blanching out at بيضة, and then later on the red colors come. Then we have the sinus, destruction of the nasal cavities. And that can be very difficult and takes years to be diagnosed, because people give antibiotic after antibiotic, do surgery, and then the end is severe destruction and all is Wagner's. Scleritis, and even can go up to blindness sometimes. We can see ground glass opacity here and pulmonary hemorrhage. When patients spitting blood or have a cavitary lesion, we worry they can die overnight from too much bleeding per like lung. And then we have lung nodules and masses. And what we see here in basically in the lung. And then we have necrotizing glomerulonephritis, what we see in the lung here. So everywhere can be involved with nervous system. We have like wrist drop, foot drop. We have abdominal vasculitis in the abdomen, and this causing severe vasculitis and causing bleeding and gangrene in the stomach. Cardiovasculars, the heart can be involved with also in this vasculitis of the small vessels of the coronaries. Throat and ear, we have otitis media and sinusitis, eye, and chest, renal, and cutaneous. What we see here, these things. So the incidence is not big, 3.3 cases per 100,000 a year, but can be go up recently more. We have increasing. Why it's increased? Because now improving survivals, we have recurrent of vasculitis and more diagnostic. Now with the tests that we have, we're better diagnosing, more awareness. So typically we have like, this is more numbers than before, and typically also occur between 45 to 75 years old. So the ANCA-associated vasculitis, we're focusing on ANCA. They have to have a trigger. It's a genes and something trigger it. And the trigger can be medication, hydrazine, minocycline for acne, propylthiouracil is for hyperthyroidism. Cocaine-induced actually vasculitis, almost typical, misdiagnosed big, and can cause nasal ulcers, exactly like what we see with Wagner's, and can cause also like everything like typical rashes, typical vasculitis. ANCA can be positive sometimes, see ANCA, and it can be misdiagnosed easy, and that's how it will be. But you can specific see ANCA subtypes, it can be positive or negative depending on cocaine, and that's what we see. Silica also can trigger that, and also infections. We see that in COVID. COVID triggered vasculitis very tough. And I have a publication about COVID can trigger the immune system, and it triggered the immune system like autoimmune lupus rheumatoid. We see polymyalgia rheumatica, we see dermatomyositis, we see a lot of things like that, and that's COVID done. And then basically even the vaccine, a sad thing, but we couldn't say it because it's difficult to say that here. So let's see the clinical manifestations. Again, it's actually, it depends on the disease stage and severity, organ involvement, and extension of the problem. And as we see, every area, for nerve, for example, hypothesia, athenia, mononeuritis multiplex, very common for vasculitis, purpuric rash in skin and ulcer, necrosis. We can see bowels, abdominal pain, bleeding, perforation, hematuria, proteinuria, active sediments, and kidney failure, definitely, dyspnea, and cough, and hemoptysis, stridors, and nasal ulcers, and paranasal sinus, and otitis media, and conjunctivitis, episcleritis, and iritis, and loss of vision sometimes. So this is one of my patients here, very interesting case. This guy has sinusitis for a year, and it was seen by multiple doctors, did antibiotic, biopsies, these things, nothing, no one diagnosed that, until he came and to us, and we did a CT scan shows erosion and eating the bone. He has a hole in his face, and you can put a probe all the way, can go to the brain from this kind. I got this picture just to let you know how aggressive vasculitis is. Yeah, and this is mononeuritis multiplex, wrist drop that can happen for people Saturday night, like palsy, when people drink and sleep differently and get, but vasculitis can cause that. When you see wrist drop or foot drop, you may think about vasculitis. Sometimes we do sural nerve biopsy for that, but generally it is sometimes something can be put in an eye for it. So how can we diagnose that? We have we have to do CBC to look to the anemias and kidney disease and chem panel and urine to see protein and how much protein urine, and urine protein is very important. We do GPM, ANCA. We're talking about ANCA. When you order ANCA, please order the 4 of them. C-ANCA, P-ANCA, MPO, PR3. You can't order CMP only. That's not right. Because P-ANCA can be false positive, but when you have MPO, that makes it stronger than that. We're talking about that later on. The same thing, PR3 with C-ANCA. So cryoglobulin, complement, C3 and C4, especially C4, rheumatoid factors, and all the other lupus tests. And also CT lung and bronchial lavage. EMG for you have nerve problem here. Biopsy, which the best is the kidney, immune glomerulonephritis. That's the best place to get. But you can do skin. It will end up with leukocytoclastic vasculitis. May not tell you exactly unless cryoglobulin can give you more, like cryoglobulin in the skin biopsy. Nerve is fine. Muscle is okay, but lung is fine, but very difficult sometimes because sometimes necrotic area and you don't see typical picture, but kidney is the best. So general approach. When we have to first, to have to worry about mimic vasculitis. Cancer can be mimic vasculitis very big. I got a lot of patients referred to me, high SID rate, CRP, ANCA positive, and sometimes C-ANCA positive, and they end up to be renal cell carcinoma, and this causing all this abnormality of the labs and stuff like that. So you have to be watching this. Infection, as we said, TB can be a problem, hepatitis C, all these things can happen. Medication prescribed, recreational medication prescribed one. Again, history and history. Then consider systemic autoimmune disease, lupus, rheumatoid, MDA5, which is a part of dermatomyositis. It's a test that can be done. These kids, actually young age, they get severe interstitial lung problem and pulmonary hemorrhage, and they get mechanical hands, some rashes of dermatomyositis. CK can be high, and people just dying if you don't treat them, intubated, and that's actually something we have to look for it as part of dermatomyositis. So you have to have a full workup. So ANCA test. ANCA is very important. ANCA is basically antibody to primary granule of neutrophil and monocyte. So it's a neutrophils disease, by the way, and monocytes and lysosome. It's immunofluorescent, P-ANCA and C-ANCA, but ELISA is very important, MPO and PR3, because the ELISA is 92 to 95%. So that's a confirmatory one, and you have to do 4 together. When you have C-ANCA positive, doesn't mean anything unless I have PR3 positive. So you can have 5% in GPA, Wagner's, can be ANCA negative. In MPA, you can get 5 to 10% of ANCA negative. And here is the diagnosis by biopsy. And EGPA, big because eosinophil is the key problem here. But generally, you can have PR3 common here in Wagner's and MPO common here in microscopic cholangitis. So MPO is important, and or MPA is important for microscopic cholangitis. So how can we treat that? I'm going to talk in detail about that later on, but let's see. First, when I see patient in the hospital with typical picture, pulmonary hemorrhage or cavitary lesions or kidney disease involvement, and they did some ANCA, takes a week to come back, still the T-ANCA positive or something, and these patients have full picture, high SID rate, CRP, anemia, all these things. They ruled out infection for the first week, and I'm sure it can be like vasculitis. What should I do? I pulse steroid. I pulse steroid 1 gram daily for 3 days, and this is what we do. And then after that, during this, I do biopsy. Biopsy came back from kidney, came back tricentric or ANCA vasculitis. At that time, I will choose between either rituximab or cyclophosphamide. Rituxan is better now. Rituxan is easier, especially for kidney disease, kidney failures. You don't need to adjust to the dose according to the kidney disease, because cyclophosphamide, you have to adjust 50% of the dose if you have a kidney problem. But Rituxan is simple. Same dose, 375 milligram per square meter weekly for 4 weeks. Some people do the 1,000 twice, but I'd rather do the 375 weekly for 4 weeks. And then after that, you can do both, it's fine. You can do oral Cytoxin or oral or IV Cytoxin. Once you go for after that, you can continue on the prednisone after you do the induction with the prednisone high dose, 1 milligram per kg, 60 to 80 milligram daily. And then you taper down slowly by like whatever 20 milligram, you go to less than 20, you can go slower than that. And every 2-3 weeks, and that's what we do. But what we reach remission here, which patient start feeling well, inflammations better, kidney function start to improve, lung cavity start getting smaller, or at least the hemorrhage will go down, infiltrations. So you're gonna go for sustained remission. You can choose a lot of medicine. Here you can do low-dose prednisone with immune suppressive like Rituxan. Rituxan now became one of the best for maintained remission, which is the dosage will be 500 milligram, repeat in 2 weeks, and then after that, 500 every 6 months. Or Imuran is a great drug, or even methotrexate is fine drug. We'll talk about that in detail now. And there is basically, we have multiple, depend on how it will be and to maintain that. But the treatment is tough because we give 3 gram steroid in the first, like mesalprednisolone in the beginning, and then you give 60 milligram per daily for big number, and then you give rituximab, you wipe the epi cell. The risk of infection will be high. Hypertension because of steroid will be big, plus the kidney involvement. Diabetes because of steroid will be big. Osteoporosis, fractures can happen. So we have a lot of things can happening. So we have to watch out that this is therapy stuff. And that is actually a schematic way that American College of Rheumatology give us now recommendations. And the recommendation for patient for severe ANCA, GPA, or MPA, you just recommending exactly what we said, pulse dose steroid, then Rituxan or Cytoxin. They like more Rituxan more than Cytoxin. And if patient remission, you can maintain that either Rituxans or basically you maintain with anything else, like, as I said, methotrexate or others, or Imuran. But if patient is no remission, you end up to be either switch from Cytoxin to Rituxan, or maybe combine. We're talking about that later on. And that's what it is. If it is limited Wagner's, which is somebody with sinusitis only, or somebody like have like simple upper respiratory tract or mild lung involvement or very mild, you can even try with simple either Rituxan or Cytoxin, but you can even give methotrexate as a treatment with steroid. Methotrexate is great for limited Wagner's, so you don't need to big gun of medication. So the problem we're facing is relapse. So the relapse happening. 50% of patients can get relapse. So after you do the remission, you go for remission, you can maybe within a year or two, you can within even 5 years, you can get relapse. And relapse is a problem. So what we need to be done? Who's gonna get relapse? Younger age can get relapse more. People have PR3 continue to be positive. Or positive, this PR3 when high level is a problem, and continue to be positive, you can be relapsed. We don't worry much about, I do ANCA like as one of the treatment, like measurement later on during the after inductions every few months, every 3-4 months. But if I see one somebody negative became positive, it's a problem. But you can have positive all the time, doesn't mean much. So it depends on the change happening or something like that. Patient who has GPA has more relapse, lung involvement has more relapse, and cardiac and upper respiratory tract problem. And patient have like kidney problem, prior relapses before, ENT involved skin. People have therapy, discontinued therapy, you stop because of infection, you can get relapse. People are like, did not take the full dose of cyclophosphamide because of kidney disease, you give them 50%. People on mycophenolate. Mycophenolate is not a good drug for maintenance. It's different than lupus here, but mycophenolate does not show much here. And B cell coming back. So some people measure anti-CD19 after Rituxan, so it checks the B cell. And some other patients who have like HLA, DP1, whatever, they have some genetic reason for relapse. So relapse can happen. So that's new. That's what we do now in our adding to our, because in the last years, we don't have much other than Rituxan as approved for this, which is like in last 7, 8 years, but now we don't have much of new medicine until recently. In the last 2 years, we have a new drug just approved called Tavneos or avacopan. Let's talk about it. So ANCA-associated vasculitis is, as I said, neutrophil disease, which is basically we loss of immune tolerance of ANCA. So that what's happening, this is the ANCA, the MPO and PR3 begin against that, and that's what's happening in neutrophil. This is a neutrophil, and this what's happening in this neutrophil priming, which is come this MPO and PR3 to the surface. And if neutrophil get exposure, getting more cytokines, inflammation markers, all these cytokines come in more and more, and that's what we call complement 5A. It has something to do with this activation of neutrophil, get complement 5A, and this causing downstream molecule and causing more inflammation on the surface of the blood vessels, which is small vessels, causing inflammation, complement 5A receptors in neutrophil destruction, and causing mediator cause severe destruction, that's causing tissue damage. So we go back to first year of medical school when we have the complement cascades, a classical and lectins. We have all this until we reach to C5 and all this C5 convertase, and then we go for alternative pathway. And that's very important in this ANCA disease because in this C5, go to C5P through C5A receptors. And that is pro-inflammatory in ANCA and causing activation of the small vessels and causing too much cytokines. Here it comes to the Tavneos. Tavneos blocks C5A to go to C5A receptors. During this block, which is great in mechanism of ANCA vasculitis. The drug is expensive. This is preclinicals and studies in monkeys. You know that I do a lot of clinical trials. And I tell you, clinical trial, very interesting. You go for preclinical with animals in phase 1 in human and normal people, then you go phase 2 and 3 and 4. 4 is after approved drug. But generally, I was recently in one of the biggest center. I love to share this story with you. Biggest center here in Los Angeles, actually for phase 1 trial. And this is normal people, completely normal. They try low dose of drug to see how effective it is. And these people actually very interested. They pay the money. They get $70,000 to get in the trials for whole year. And then they go, for example, for trials, 2 weeks trial, they lock them in, they stay in the place, they get the new medicine, and they go for this month, take drug for like vasculitis, next month for lupus, months after for smoking, months after for diabetes. And there's these people who agree about these trials. And you see a lot of students that come from overseas, Japan or others, they go involved in this trial. They don't do it in their country, they do it here. So phase 1 trial is very unique, but this study was done pre-phase 1. This is for animals. They saw decrease of neutrophil when you add Tavneos. And he decreased avacopan, all the neutropenia in this. So the study was done for avacopan or Tavneos to then comparing Tavneos 30 milligram twice a day, adding to the standard of care. You have to add a standard of care, rituximab or Cytoxan, and followed by immunotherapy Cytoxan. And then, or you give, but no steroid. He did not give a steroid. So we can call it steroid-sparing agent. This drug is expensive, by the way. Is $150,000 drug per year. But comparing to people taking the standard of care and steroid, prednisone 20 milligram and tapering down to over 20 weeks. So this patient take a lot of prednisone. This patient take almost the induction dose, the beginning dose only. So, and in this study, they found that, first of all, is not inferior to prednisone in achieving remission. So both of them get to remission, not inferior, not superior to. But at the same time, it shows that it's statistically superior to prednisone in achieving sustained, actually, like basically remission, maintained remission. Better. You see the numbers is better than steroid, like Tavneos, 65% and 54% in prednisone group, only sustained. The other prednisone group can go for relapse. These patients on Tavneos saved a lot of prednisone. So this is 81% median cortisone load, like 3,000, like 800 compared like to 1,000 here, the group of Tavneos, or 3,000, which is 3 grams and above, and this one 600. This is after the induction dose. Big number, so saving a lot of dose of prednisone. That would be great for somebody is diabetic, cannot take steroid and develop vasculitis, or cannot, for some reason, cannot take too much steroid. So it make us decrease the load of steroid and also decrease relapse. They have less relapse rate, 10% compared to prednisone group, 21%. It's also work well for kidney, better kidney function after some time. So the kidney function here, the group of prednisone, is less improved. It is much improved in the 26 weeks and is even better in 52 weeks for people who take. So people who take prednisone alone, they have not preserved full kidney function. Vasculitis is one of the diseases that if you treat patients, we got patients on dialysis, if they are early diagnosed dialysis, and put them back on remission and go to normal kidney function if you treat quickly and early. That's why it's important to treat early and quickly. So I have patient myself, creatinine 5 and later on 0.5 after you got full treatment. So this is helping in improving the kidney function. Side effect is not a lot. You know, I have few patients on it, like maybe 5 patients, and nausea, headache, and hypertension, diarrhea, fatigue, stuff like that. But the main thing is saving a lot of prednisone for this patient. Hepatotoxicity, they don't recommend anyone hepatitis C to take it, and anyone has kidney, like liver disease, and serious hypersensitivity can happen, which we don't see that cases very few in clinical trial. So it became part of standard of our care to add it from beginning, Tavneos. So basically what we are doing now, when I see patient in the hospital with vasculitis, I think it's vasculitis, I start with a mini pulse the patient. I don't need to give 1 gram daily for 3. I may give 500 milligram IV daily. And then I start Tavneos, and then I do biopsy, and I start Rituxan or Cytoxan. I usually start Rituxan. And then after that, I go on and with Tavneos all the way for 1 year. I'm currently doing clinical trial in my office for 5 years because they think we can maintain with Tavneos alone, but up till now, it's part of its clinical trial. So we'll see what's going to happen after these 5 years. But let us talk about Wagner's again in a different way. We'll talk about difficult cases. So we have induction of remission in severe case. So if somebody severe case of Wagner's and you need to go for remission, so basically, there is a RAVE trial that shows that rituximab is non-inferior to Cytoxan in making remission. That's great. And then there is another study show that you can sometimes in severe cases, you add Rituxan plus 2 IV doses of Cytoxan, or IV versus IV Cytoxan similar, and they found that it's a similar remission rate. So you can, if somebody's severe, you can go for adding on Rituxan, Cytoxan. I did not do that before, but this can be mentioned here. So majority of patients getting now Rituxan plus steroid. In 2021, ACR guideline recommend Rituxan over Cytoxan in severe cases. Cytoxan continue to be option for, I think Egypt can be part of it because sometimes patients cannot afford to get rituximab. So Cytoxan is a good drug. Availability and cost is the key, actually. And efficacy is also seen in ANCA negative. So Rituxan, you remember, Rituxan is not good for ANCA, for rheumatoid negative patient for rheumatoid arthritis. But in ANCA negative, they found it's okay, it's working. And we see also the FDA as the approved dose for rituximab is 375 milligram per square meter weekly for 4 weeks, or you can go to 1,000 milligram every 2 weeks. For patient who is in remission for severe disease, can be methotrexate is a great drug. Is for non-severe disease is okay, and lower toxicity. For remission, for induction, for somebody nasal problem, sinus problem, mild lung problem, methotrexate can be okay drug. And especially with rituximab, we worry about vaccine. You remember during COVID, vaccine will be big problem. We have patient died from Rituxan because during the COVID, because of the immune system is wiped completely B-cell. So now is not a big issue now. So basically we have non-severe, non-renal disease. We can use only methotrexate versus Cytoxan, sometimes oral, and the remission rate is similar. So there is no difference in methotrexate and Cytoxan. So definitely methotrexate would be good for limited type Wagner's for remission or for non-severe cases. Now we finish with remission, go for maintenance, maintained. There is multiple trials, and they found that Imuran is effective as Cytoxin. So I will go for Imuran, safe drug, an easy drug. You know, sometimes we do TPMT before we start, for like enzymes, to be sure patient is not having deficiency of the enzyme that break Imuran. Methotrexate and Imuran had similar efficacy in maintained remission, so good ideas. Mycophenolate inferior to Imuran, so mycophenolate has no place much here unless you have to. But we're talking about there is multiple trials, and they found that first of all, still rituximab, I'm doing that myself. Once dose every 6 months, 500 milligram can maintain remission better than Imuran. So Imuran is great, but if you can afford them, patient can afford, why not Rituxan every 6 months, one dose only 500 milligram to maintain remission. And they also found in the other studies, Rituxan 500 every 6 months versus tailored arm. They're looking to, people don't give it every 6 months. They give it, check CD19 B cell. If the B cell start going down or wiped, like start come back again, you give Rituxan dose. So you give it based on the blood work when the B cell come back. Okay, that's another idea, but they found low rates relapse and there is no difference. So you can do it every 6 months. You can do it even every 8 months or 9 months. It depends on the B cell coming back or not. And they found also the third way, patient completed this mainstream two, and they found the Rituxan every 6 months for 18 months compared to placebo infusion. And they found that the higher rate of relapse when people did not take maintenance. So you have to have a maintenance, either by doing Imuran or you're doing methotrexate, or you're doing Rituxan for a long time, but you have to do maintenance. So the maintenance therapy, Rituxan is currently the most common drug used in the United States as a maintenance, and 500 milligram every 6 months is enough. The optimum duration of Rituxan can be 2 years, and they don't know, maybe go more, but when to stop? That's a tough question. When you have 2 years of remission, you have you stop first prednisone, and then you are now in remission, your blood test is good, no protein in urine, lung is good. Sometimes I follow with sometimes somebody cavity lesion, 12 centimeter, I follow them up, CAT scan every year. I found this is going down until it healed completely. So the cavity healed. I have no protein urine, kidney is fine, everything is okay, ANCA level, it's okay. Can be negative, can be even positive for a long time, no change, I'm happy. Even there's no change, is okay. So at that time, I may stop after 2 years of complete remission. And that's actually, they said, that's important to be looking for that. So we have induction of remission and or maintenance. We know that Rituxan and glucocorticoid plus or minus avacopan, if you can, is great. For severe disease, you get Cytoxin, glucocorticoid, or avacopan. And for non-severe case, you can give just methotrexate or sometimes Rituxan. For maintenance, Rituxan every 6 months, Imuran, methotrexate, or even mycophenolate if you cannot use methotrexate, patient alcoholic or kidney disease or anything like that. So that's or homozygous for the gene for Imuran. So the challenge in GPA is failure to achieve remission, which is basically patient's improvement, insufficient response. The cavity lesion is still there. The kidney function is not improving. The proteinuria is still high. And progression of the disease, a new manifestation, that challenging organ-specific manifestation, more damages or something like that, that's a problem. And distinguish active disease from damage. So there is sometimes you have a damage already done. Your kidney failed, done dialysis. Nothing can be regained. But the point is you tried and nothing. No, that's damage. But active disease is a different story. So we have to differentiate, is it active? Or it's because you failed because it's still active, or we have organ damage. If we have a failure to achieve remission, every disease is active at 6 months. The RAVE trial still tell us there's 64% of Rituxan patients and 43, they can get remission, but there is 40% they don't get remission. So not every patient get treatment, get complete remission. So we still have numbers. They can be more 18 months will be better, 74%, but still have 25%, they don't get remission. And there is patients actually get damages to sinus, damages to nasal, damage kidney function loss, neuropathy and maintain neuropathy, eye problem, and all these things. Or patient develop infection, and that's another problem can challenging. So the treatment of persistently active. So now the 25% that make us trouble, you can repulse steroid more. You can switch main therapy. If you start Cytoxin, give Rituxan. If you start Rituxan, give Cytoxin. You can combine it. Rituxan, Cytoxin, and watch out for infection. You can give 2 doses. You can give 50% dose of Cytoxin. There's protocol. You can add IVIG. You can do plasmapheresis. I do plasmapheresis when somebody comes in the ICU intubated with lung problem and kidney problem, lung infiltration. It can help. IVIG may help, but it's not huge, but it is there. So non-severe cases, actually, we can do increased dose of steroid. You can change methotrexate to like subcutaneously, or you can repeat induction with Rituxan, switch from methotrexate to Rituxan, or you can do abatacept, Orencia, the treatment we do for rheumatoid. But we have a medication that's actually there is study now, and it's called eptinezumab. It's given to the cancer patient leukemia, and they found it worked very well for these cases of which is basically very active. Rituxan plus belimumab, anti-Ples, which is it's in Egypt. It's Benlysta. It's there in Egypt subcutaneously, and tolzuzumab, Actemra. There is abatacept. There is a lot of things you can do for failure of Rituxan and Cytoxan. So how about relapsing? Relapsing, which you already went to remission, great, and then all of a sudden start to activate again. This is some patient, as I said, 50% can go up to 80% in 10 years. High rates of relapse when maintenance therapy discontinue. So if somebody get infection, you stop the drug, or diabetic, you cut down steroid dose, and you end up to be not full treatment, you can get kind of relapse. So we have increased exposure to steroids, increased risk of infections, and all these things. And basically, you have to be early identify this patient because you can start from beginning full treatment. And the factors, as we discussed it before, PR3 is big here. Diagnosed GPA is a problem. Patient is on like Cytoxan as opposed to Rituxan, and persistent ANCA positivity. That is cause factors that will tell you this patient will get in relapse. There is no good predictor of relapse. Even ANCA level is not big predictors. But if you see changes, you were negative and all of a sudden became positive. Benefit relapse prevention is way against the risk of immune suppression. These patients already and hypogammaglobulinemia. So you know that rituximab, some people measure IgG, IgA, IgM, and if it's those IgM is low, you can give them IVIG, 1 dose or something to help that. So that's a problem. So damaged, if there is a damaged or any kind of damage, as we say, tracheobronchial disease or visual loss, sensorineural or kidney failure, and poorly controlled diabetes can be tasked for it. So for relapsing, you do treat as starting from beginning. You do either Rituxan, first option, or again, cyclophosphamide like Cytoxan, combination therapy, as we said, and low dose, and still you can give avacopan if you want. For non-severe, the same idea as Rituxan. You treat as remission from beginning. Avacopan, you can, up till now, is not studied for maintenance, but we do study 5 years for now. We have long-term monitoring. We monitor patients generally, assess the disease, very important, patient education, clinical evaluation, regular lab, CBC, panel, all these things. We have treatment toxicity, BJP, which is like prophylaxis, which is Bactrim. We give sometimes like Bactrim 3 times a week. You know, with Wagner, we always do that, and 3 times a week Bactrim for that prophylaxis, PCP prophylaxis, and reduce dose of steroid as much as you can because cortisone can be a problem. So in conclusion, this area is basically improvement, survivals, remission, relapse rate is management. You have, that's important. You remember long time ago before Cytoxan and Rituxan, even we have the death rate was almost 50%. Well, now the number is going down to even less than 10% with the therapy we have. So we have to unmet needs. There's still patient get couldn't control remission, go to remission because of the therapy is not working. and we have to predict therapy, treatment, reduce response rate, prevent organ damage. The key is the kidney stop before dialysis, treatment toxicity, reduce the need for low dose like steroid, tapering the disease. That's why we have the avacopan here for that. And Rituxan, it became a primary treatment of choice and maintain remission. And that's for even for non-severe and severe cases. And methotrexate work, optimum dosing and interval of Rituxan and is important. Maintenance itself is not shown until 2 years, but there is more study now. We have to explain and actually all the knowledge of pathogenesis to improve therapy of this disease. And we have to have monitoring regularly for this patient who cannot leave them. So what is coming? That's an important. There is a lot of things because, again, I'm fond of trial. I love trials. I did almost more than 100 trials in the last 20 years. And I enjoy developing of new medications. I be part of it because you know what's going to be happening and what's going on. So there is a use of tofacitinib. It's in Egypt, actually, Xeljanz. JAK inhibitors, there's a study for now for that. Belimumab Bliss in the maintenance treatment. Use abatacept for the treatment of relapse, non-severe GPA, belimumab, which abatacept, which is basically, it is Orencia. Use of rituximab and belimumab together for combination. It's the study for that. And actually the revolutions of therapy in the United States called CAR T therapy. There is 28 clinical trials in the United States about CAR T. All pharmaceutical companies, crazy about CAR T now. And this is a very interesting therapy. So we have it for all diseases. First of all, it shows it can put cancers in not remission, even cure it almost. Some cancers. So maybe it's a hope one day. So for that, especially lymphomas, leukemia stuff. But they take the idea that, and they tried on 6 patients on lupus, and and this is severe, tried everything, nothing worked, lupus nephritis, and make a huge change. No double-strand DNA, complement back to normal, no proteinuria, kidney function normal, and patient not immune suppressed much. So they're getting excited. So every company now having CAR T therapy on it for rheumatoid, for vasculitis, for ankles, every diseases now, and everyone competing. The problem is expensive. The one therapy used to cost, until recently, I heard $1 million per one patient, but will go to $500,000. I don't know what's this, but let me tell you the ideas quickly. It's basically take blood from patients and basically take that T cell and make it cytotoxic T cells, make more energy, like more active cytotoxic T cell, and they do it in vitro outside for 12 days through process, go through it, make it very cytotoxic, and put it back in the patient again, and starting eating all the diseases, all the problem, and fighting all the cytokines, and putting the disease in remission. That's an idea behind it. It's very interesting, and we have studies in every, as I said now, 28 trials right now. So they do one for vasculitis. We have a long-term rituximab maintenance. Instead of 2 years, go more than that. Combination therapy of Rituxan and rituximab regimen was for remission with others like Cytoxan or others. Use of IVIG in relapsing in vasculitis. There is long-term, I do this study in my office, avacopan for 5 years as a maintenance, and that's what it is. So don't forget in management of vasculitis. Number 1, bone density. Osteoporosis is big. You give a lot of steroid. So you cure vasculitis, you end up with multiple fractures. Patient couldn't walk. So we have to do prophylaxis for sure, whatever it is, Borrelia or alendronate. So GI prophylaxis because too much steroids for these patients. Infectious prevention because PCP prophylaxis. Infection is the big thing here. Our enemy is infection. Timely vaccination, don't give live vaccine during these things, but vaccine the patient first if you can before shingle vaccines, like all this pneumonia vaccine before, if you can, before you wipe the immune system and B cell. Evaluate secondary malignancy for recipient of Cytoxan, urinary bladders, cancers. Multidisciplinary approach, physical therapy, occupational therapy, support the group. It needs a lot of work. I can go for another area. It's a few areas. This is not big. If you want me to do, if you don't mind. So is it okay? We can talk quickly about cryoglobulinemia. It's very little. So cryoglobulinemia is immune globulin that precipitate at low temperatures. There is 3 types. Number 1, type 1, monoclonal malignancy, thin cancer, which is especially multiple myeloma, Waldstrom, and others. Number 2, monoclonal, polyclonal together, hepatitis C, very common, causing cryoglobulinemia. Hepatitis B, HIV, toxo, and others, so zinc infection. Type 3 is polyclonal 1, which is mixed using autoimmune disease like rheumatoid, lupus, Sjogren, and using coexistence of other autoimmune. We call it secondary cryoglobulinemia. I have a patient currently, actually, and we publish it now, and this patient has Sjogren syndrome, simple Sjogren, dry mouth and dry eye syndrome, no problem. All of a sudden, develop like paralysis, lower extremity paralysis bilaterally. We did all the workup, everything, and then we find that cryoglobulin is high, low complement C4, and then we look to the MRI in the spine, we find hematomas around the spine causing that, and it's all vasculitis, cryoglobulinemic vasculitis, second to Sjogren syndrome, causing spinal vasculitis. That's why we publish it, and paralysis of the leg. So that's how secondary can be. So what kind of symptoms? Arthralgias, rheumatoid factor positive is common. And in spite of rheumatoid factor positive, CCP will be negative. You don't have typical pictures of rheumatoid, no synovitis, no anything. So it's not clinical disease. And you can be very similar to ANCA vasculitis, especially is lung sparing. Here we don't have lung. We have a kidney biopsy showing glomerulonephritis, but generally, and can be similar to lupus nephritis. So, but you can see a good pathologist can find cryoglobulinemia in the disease. So how we diagnose cryoglobulinemic vasculitis? First symptoms are arthralgias, purpuric rash in the leg, skin ulcers, glomerulonephritis, and peripheral neuropathy, wrist drop, foot drop. This is a common question in board exam for internal medicine we have here. And because I teach board exam for doctors and in California, for medical physicians, and this is a common question. There's always a question about cryoglobulinemia pictures as. So the index of suspicion going up if clonal, for first, if you have Waldstrom myeloma, you have to think about cryoglobulin. Viral infection, hepatitis C and B, and somebody developed some joint pain and purpuric rash, think about like second form. If somebody is lupus or Sjogren, like the case I described to you, and develop some other manifestation, rashes and neuropathy, and this thing, kidney disease, because Sjogren is not causing kidney unless something secondary happened. So it can be others autoimmune, but generally this can be one of the things. So the simple thing we do measure, you ask for it, cryoglobulin in the blood. They done in different way. They have to do it under certain temperature. So regular sample is useless. Don't take it if you not tell them you do it in the right way, you have to do it, and low complement C4. So we have diagnosis, cryoglobulin level, complement C4 low, urine analysis, protein urine, high inflammatory markers. You do full lupus panel, ANCA panel to rule out others. Kidney biopsy is important, skin biopsy. It shows cryoglobulin in the skin if you look to it. Hepatitis C and B and HIV, and protein electrophoresis for bone marrows, and bone marrow biopsy also for multiple myeloma and Waldstrom and others stuff. So this is what we look for kidneys, see its membranous membrane profit of glomerulonephritis, and that's what we see. And a good pathologist can see the cryoglobulin in the kidneys here, and that is how they do the blood, and they take it in certain temperatures, and this is the vasculitic in the skin, and what we see is this rash, typical for vasculitis. So basically, treatment is simple. It depends on the types. If you type 1, you treat the underlying multiple myeloma. Type 2, hepatitis, you have to treat hepatitis C and then give that immune suppressive. You can't give immune suppressive without treatment of hepatitis. Same thing for Sjogren, you treat, or autoimmune lupus, you treat both together, but you have to be sure. So you have to treat underlying problem while you start. Rituximab for mixed types 3, and actually is not showing like for type 3, but the one that shows good effect is Cytoxin more. And plasmapheresis here is working well, better even than Wagner's one. So basically, as we said here, Cytoxin is a key of management, added to hepatitis C treatment or added to others, but sometimes Rituxan is fine for this. Our patient in Sjogren, he started to walk after he became paralyzed because of hematoma improved, and that's after we give him rituximab. So, but Rituxan is not a perfect, also much here, but generally in others, Cytoxan would be good too. So vasculitis, at the end, vasculitis, it's tough. People can die. You have to diagnose them quickly. Misdiagnosed can take years, and that can be overlap with other disease. You have to be thinking outside the box for infection, for others, because you don't need to diagnose TB and vasculitis to regular vasculitis. Small, affecting skin and renal lung. Medium, mainly systemic symptoms, high fever with loss, hypertension. Large, aortic involvement is considered the age for temporal arteritis. We have to consider underlying symptom disease, polymyalgia, other systemic disease diagnosis. Good history is important here, and review of system is important. Treatment with immune suppressive, you have to watch out for others, mimics and infection, and great advances now. I think near future will bring us a lot for this disease. And that's my last slide. Thank you. And that's my office in Covina.
Thank you so much, Professor Metias, for this elegant presentation as usual. And now the floor is open, if you don't mind, Professor Metias, for the audience to for the question. Let us start with our dear professors, and we can go to our colleagues after that. Professor Hisham, please. Professor Hisham is there? Okay. Professor Assam.
شكرا جزيلا للدكتور ميتياس في المحاضرة الحقيقة المجمعة لحاجات كتيرة قوي بما فيهم الرول بتاع الافاكوبان. هو الحقيقة أنا كنت ناوي أسأل على الرول بتاع الافاكوبان على اعتبار إن هو حاجة حديثة، بس حضرتك غطيتها في البرزنتيشن بشكل كويس. عرفنا الرول بتاعه إيه، لأن إحنا عندنا في 2024 جايد لاينز بتاعت الكيدي وجايد لاينز فور مانجمنت اوف انكا اسوشيتد فاسكولايتس started to show القصه بتاعت الافاكوبان. بس طبعا احنا عندنا مشكله كبيره في الموضوع ده اللي هي الكوست. زي ما حضرتك تفضلت قلت الكوست بتاعته بتبقى عاليه قوي، $150,000 per year. This is too much in our country بالنسبه للاستعمال بتاعه. فانا تصوري الاستعمال بتاعه مش هيبقى يعني قريب عندنا في الحالات اللي احنا بنستعملها، وهيظل برضو الرول للادويه الافكت بتاعها معروف، زي الريتوكسيماب، السايكلوفوسفاميد، الكورتيزون. برضو من ضمن الحاجات اللي هي لاكينج عندنا احنا in our country موضوع ان احنا to take care من الانفكشن اللي ممكن تحصل للعيان، ان احنا ندي للمريض بروفيلاكسيس اجينست البي سي بي. مش دايما بنعمل الحكايه ديت، ان احنا تو تيك كير من الفاكسينيشن. اي ثينك دي من ضمن الحاجات اللي هي بتبقى ديفكتيف عندنا شويه. انما اذروايز حضرتك وضحت الرول بتاع الكومبلمنت انهبيتور اللي هو الافاكوبان. فبشكر حضرتك يا دكتور سامي على البرزنتيشن الجميله بتاعتك.
اشكرك. اللي انا متوقعه يعني هو طبعا هو الثمن هنا غالي، ان هو طالما اورال تريتمنت within فتره يعني هوبفلي بسيطه هينزل قريب اسعار رخيصه. يعني زالجان فور اكزامبل اللي ابتدى عندنا 50,000 النهارده متوفر بمصر باسعار قليله يعني. فيعني اي ثينك طالما اورال يعني هتبقى it's so easy. Same thing with hepatitis C treatment. is all this changed and became very easy to be made. Europe can be made it with something approval طبعا من الشركه هنا. بس generally Amgen take over now، اشترت الشركه. فيعني I think ان ده هيبقى rule later on. So I'm expecting it's nice to know about it. That's why I mention it. لأنها ممكن جدا within few years هتبقى available بأسعار رخيصة. إنها حاجة سهلة إنها طالما oral can be done.
تمام. بروفيسور مجدي الزير. Okay, please, Professor Amr, we wanted to hear from you.
Thank you so much. It's a fantastic presentation. I really like it, Dr. Sami. Just a quick question. For the chemocentric study, the advocate study with the avacopan, I thought they failed to show a good evidence to the FDA that avacopan can replace steroid. So I think the FDA approved it not as steroid sparing, but
Yeah.
as adjunctive therapy. Can you please let me know if I'm mistaken anything here?
That's exactly what it is. So I'm actually, I tell you, what we're doing in real life, which is, yeah, we first of all, it make me have those steroid, like not first in the beginning, I can give like 500 daily for 3 days if I'm available to give avacopan. And then I can start 60 milligram prednisone with avacopan, and then I can quickly jump down. I can go to 40 within maybe a week or 2, and then go to 20, and then go to 10, and then go to 5, and stop prednisone within 4 or 5 weeks. I can't do that in a real life. So الفكرة كلها ان الاستادي as you said it's not different. يعني حتى انت لما شفت في الاخر لقيت ان هم 600 ملغ different than induction. ففي ناس خدوا وفي ناس ما خدوش. فهي it's not a full replacement of steroid. But it's just like together, but at least you can cut down. So it helped me في البراكتس. في مين بقى؟ العيان بيجي لي مايكروسكوبيك بولانجايتس، بيجي لي من نفرولوجيست وعندها ووجد all of a sudden kidney like start getting worse، عمل بايوبسي متوقع انها diabetes، هي diabetic، end up to be vasculitis، ANCA positive. Do something. Patient عندها very bad diabetes, hemoglobin A1C is 10. What should I do? Avacopan helped me in this patient. I can actually not give higher dose steroid. I don't even sometimes do the inductions like steroids, like big with steroid doses or something like that. And they have عيانين زي كده وقدروا يعني ايه يتحسنوا بأقل كميات steroid. فهو it's not a full replacement steroid. Yeah, completely. But it is for maintenance. هيفرق معانا برضو لو هو بقى maintenance، لو بقى مثلا سعره كويس وبقى maintenance، هيبقى جود ان انا مش هدي ريتاكسين، مش هدي اميوران، انا جاست هدي حاجه not immune suppressive. We have to know avacopan is not an immune suppressive drug. It's not suppress the immune system. It's just blocking C5a without causing infection rate high or anything like that. ده عملت لنا بدي الدواء بدل البريدنيزون، ما عنديش مشاكل في الاميون سبريشن. فدي برضو من الحاجات الكويسه يعني.
Okay, thank you.
شكرا. Just one more question if you allow me, Professor Saeed.
اتفضل يا باشا، العفو.
Thank you so much. Is there any rule for calcineurin inhibitors, especially the newer, voclosporin? We know that nephrologists, we love and hate calcineurin inhibitor, it's a double sword. But anyway, when it comes to vasculitis, the studies, I think, and the evidence might be different, compared to lupus. Can you please comment on that?
You are right. انا مش حتى انا رجعت كل الكلينيكال ترايل ذات جاف، ما فيش ولا ستادي داخل على السايكلوسبورين او فالكوسبورين. فدي كانت غريبه قوي. يعني دي حاجه كده. بس احنا برضو بصيت انت عملوا ستادي هي المايكوفين اللي تلاقوه ان هو ملوش وجود تماما. يعني ايه؟ يعني يعتبر من الحاجات اللي يفضل ان هو ما تتعملش في الفاسكولايتس لانها much less than even اميوران. فبيزيكلي I will not recommending unless يعني هو خلاص you don't have any options. عايز تحط سايكلوسبورين، انا عارف انه سايكلوسبورين بيستخدم كتير في مصر و cheaper and easy، لكن or tacrolimus، but ما فيش ستادي عليه ومش شايف ان هو في افكت عليه. فانا I'm not using it myself. I'd rather take methotrexate, Imuran, maybe if mycophenolate sometimes as a lower for that, or even combine Imuran and methotrexate if I need to. But generally ما فيش حاجه. You are right. Like tacrolimus, like valcosporin مش شايف له حاجه مع انه في اللوبس نفرايتس big.
Thank you so much.
Any more comment, بروفيسور عمرو؟
لا كده كفاية. أنا عشان أسيب، أنا شايف فيه أسئلة كتيرة مع حضرتك،
يا باشا
ألف شكر
تنورنا.
دكتور سامي.
العفو.
شكرا.
بروفيسور فيصل شاهين.
شكرا بروف سعيد. Prof. Sami, excellent talk. I learned a lot today. Because we are nephrologists, we want to learn about the patient who is not responding to medication and went to end-stage renal disease and have dialysis or transplantation. What is the management for such patients?
Okay, for dialysis patient, which I got a lot with this patient with vasculitis, and if it's early patient dialysis, say that patient's recently diagnosed and went to dialysis, came to the hospital with kidney failures, start dialysis, I will be very aggressive with this patient because as I said, I was able to bring kidney to almost normal or good normal, like creatinine 2, with aggressive treatment. Rituximab, I definitely go for Rituxan and steroid more than anything, because Rituxan I don't need to manage يعني change the dosing and all these things. Plus I can work it with dialysis, like after dialysis or something like protocol, and it will be fine, and we're able to get good response with pulse steroid and Rituxan and all these things. And later on, I will continue maintenance with Imuran or even mycophenolate sometimes. But basically, for patient who is in, like now, in vasculitis and on dialysis, it actually, we do not see that aggressive diseases in dialysis. Dialysis dialyzed even the antibody maybe, and we see the same like with lupus, but still in lupus, we see lupus nephritis on during dialysis, and dialysis doesn't mean remission. But at that time, I will be very focusing on the organ damages other than kidneys. Like say that I'm protecting the sinuses, I'm protecting the lung from lung like hemorrhage and all these things. I will go even sometimes give rituximab. That's a good one. Imuran is fine. I can steroid. I keep them some steroid, maybe avacopan. There's no contraindication kidney disease. So I will be like this, but to prevent other end organ problem, like especially lung hemorrhage or all these things, if they started this way, or maintain maintenance lower dose of Imuran prednisone. So if somebody early in dialysis and the kidney failure happened because of vasculitis, I'll be very aggressive to return it back, because I am successful most of the time to return it back and stop the dialysis later on. But if somebody already on like biopsy shows scar tissue and stuff and done, I will be watching over the others, like in the organ lung and other things.
Great answer, Professor Sami, but just I want to comment that regarding the antibody, it cannot be removed by the dialysis. You know, the molecular weight is very big, can be removed by plasmapheresis or TBE.
Yeah.
But as you know, I think it is the uremia itself, or the end-stage disease status of the patient, it is immunosuppressive, or the patient is already in a state of immunosuppression. So maybe you mean this, huh?
Yeah, exactly. Yeah,
Okay.
I'm just telling you, joking. I
know.
We learn from our professors in lupus in USC that don't think that patient dialysis mean remission for lupus. Lupus can be active. So we do this, and we have to handle medication accordingly. Yeah.
Right, you are. Yeah. And we should adjust the dose of this anti-malarial and this also other drugs. So it is very challenging dilemma.
Yeah.
Okay, thank you, Professor Sami. Thank you for our professors. Dr. Mahmoud, can you go through the chat quickly to read the questions to Professor Sami, if you don't mind?
Okay, Prof. The first question from Ibrahim Omar, Dr. Ibrahim Omar, you mean that these medications can cause both immune complex and post-immune vasculitis? You mean the propylthiouracil and the medications that you told about, the Prof?
Yes. Please raise your voice a little bit.
Okay. The second question is P ANCA and C ANCA different from MPO and PR3? I think it was clarified by our doctor that neutrophil and the ELISA testing is more specific and more accurate. Actually, obtain the 4 tests for
For first question, drug-induced vasculitis is common, okay? And I see it. And I always review once I have patient vasculitis, even ANCA test positive, I always review the lab test, the medication, because I saw myself propylthiouracil. Most of medication for rheumatoid like TNF can cause vasculitis. So we have to do that. Once you stop the drug and you treat. You have to give some steroid and maybe some methotrexate or maybe some Imuran. You don't just stop the drug and watch over, because it can cause some problem. So you have to stop the drug, number one, and then you start treatment. And this patient, you don't need to put them for long-term treatment. You just treat for a week or 2 or 3 or whatever months or 2 until you go for everything calm down, citrate went down, and everything is good, and you stop the drug, because the drug is the agent that causes that. Minocycline, guys, is big thing. You know, for acne girls, young girls with acne or young boys acne, and that can cause a lot lupus and can cause also some like vasculitis. So we have to watching over that. For the second question, again, I'm telling you, when you go to see a consult in the hospitals and you have C ANCA positive and kidney failure, doesn't mean it's vascular until you do PR3. So C ANCA with PR3 means something. C ANCA alone, you have to watch over this. And then same thing, MPO and P ANCA. So ELISA is 95%. But the others can go to 50%. So C ANCA can be a lot of consult come to me, P ANCA positive, useless. It doesn't mean a lot of diseases causing P ANCA positive. Sweet syndrome cause P ANCA positive. A lot of autoimmune cause P ANCA positive. There is P ANCA associated with rheumatoid and lupus and others. So not every P ANCA mean microscopic cholangitis. You have to have MPO makes difference when you have both together.
By the way of this medication-induced vasculitis, Professor Sami, it was maybe 5 years back or more. It was a big row regarding this montelukast or anti-leukotrienes can trigger this EBGA or Churg-Strauss in this such advanced patient. Did you face cases like this?
Yes, we have cases like that. Yes, yes.
Yeah. Okay.
And it happened when even when you stop it. You stop it, you get all of a sudden you get vasculitis started and eosinophilia. I have patients EGPA in my office now. I give them the new drug mebrelizumab, which is Nucala, and it's injections every month for eosinophils, and this causing vasculitis, difficult vasculitis too, and can affect the heart and stuff. And this is the patient has asthma and they take these drugs and all of a sudden stop the drug for some reason, and all of a sudden vasculitis started. Yet we see these cases. Yes.
Okay, thank you. Okay, Dr. Mahmoud.
Dear Prof, can we say that most of drug-induced vasculitis can be MPO associated, not PR3?
MPO and not PR3?
Yeah.
Yeah, as I said in my tables, there is percentage and even like some 50%, 30%, but MPO usually come with P ANCA. MPO with P ANCA and PR3 comes with C ANCA. And there is ANCA negative vasculitis, and that's what we have somebody come to your, like with kidney problem, proteinuria, you do biopsy, and you do ANCA negative, and you do biopsy, came back cricentric and typical like this pussy immune vasculitis. So you can all lab guide you, but not treating you. Treat or tell you more. It guide my thinking, but is not final. Biopsy is big golden standard. So, but again, MPO with P ANCA, PR3 with C ANCA. You can get Wagner with some P ANCA positive. It's fine. You can get like microscopic cholangitis. C ANCA can be a little bit positive. So you can get all kind of diagram, but definitely pictures, clinical pictures, plus some lab, plus biopsy can tell you more.
Okay, the second question, title role in treatment plan, especially in plasma exchange. Is there any role for high titer or not?
You know what? That's important. I did that plasma exchange for one patient. When I see the hospital patient has pulmonary hemorrhage, intubated, I get to these people like all of a sudden and kidney problem and ANCA positive. And you know, I do pulse steroid, I do Rituxan, and patient still intubated, I get plasmapheresis. So basically, when patient has aggressive disease, you can add on. The rule is maybe, and there is study now, that I see now showing that, but can be helping when somebody severe case and not responding to medication. It's an add-on, not a treatment by itself. So it's an add-on for severe case. After you do the standard of care, you can add on to help your case, but it's not a number one. Some patients don't need it. You just do wonderful, just steroid and Rituxan or steroid Cytoxan. You don't need the plasmapheresis, but it's an add-on because you do everything. You still patient sick, you do it.
Yeah. Second question from Dr. Omnia Hashim. When to consider it as a refractory disease and the indication of combined rituximab and cyclophosphamide in induction of remission?
Refractory disease. Consider the treatment.
Yeah.
علي صوتك شويه محمود الله يخليك علي صوتك.
هو refractory disease, the treatment, as I said, if you start the patient on Rituxan and still you don't get much of it, patient still hemorrhage, pulmonary infiltrate and this, you can switch to Cytoxan. You finish the induction 4 doses of this, you can switch to Cytoxan. You pulse steroid, you can up your steroid dose. For us, you can add avacopan. So you can do all these things. Or you can do Cytoxan combination, and you can Google it, actually look to the actual dose. You can give 2 doses Cytoxan plus 4 Rituxan dose. So you can switch from one, and this is what happened in RAVE trial. RAVE trial starts Rituxan, and patient is not responding, you switch to Cytoxan. So you can do that. Or you can do like together sometimes. You get 1 dose, 2 weeks Rituxan, and then 2 weeks you get this dose of Cytoxan or something like that. So that can be done. So refractory can happen. And you have to be very aggressive with this kind of diseases. And now you add plasmapheresis for refractory or something, or IVIG if you want. So that's how it is.
Regarding the cyclophosphamide, Professor Sami, I think you face the issue of this fertility issue, and so especially in the young patient, either female or male. Did you do cryopreservation of ovum and or the sperm for this patient? You face these problems sometimes in your practice?
You know, in the beginning, yes. You know what? In the beginning, when we think this way, we used to give Lupron for prevention of ovulations, and we used also to give sometimes we give Mesna, sometimes not.
Yeah.
We start to get away from that here. I'm telling you my own day. And even teaching, we don't have that much. Because honestly, I'll tell you the truth. We are a little bit more away from Cytoxan. So I only use Cytoxan when I get refractory or patient cannot take Rituxan or something like happen like this. So I use it. So we are less Cytoxan than before, even for lupus nephritis or others.
Yeah.
And this European dose of lupus nephritis, 500 milligram every 2 weeks for 6 infusion, 3 months only, is not a big dose to cause like this. But honestly, if somebody young, I will try to be away from Cytoxan as if I can give Rituxan here. I have patient one time, she went on and is ovulation, stop ovulation, hot flashes in young age. And honestly, it can be a big lawsuit for us here. So Lupron is a difficult drug. It can be have a dosing to be given and all these things. We used to give it aggressively, but it's also causing a lot of problem and hot flash, other stuff that patient cannot tolerate it much. So if we can be away from Cytoxan young age, it's great, especially if somebody is still in productive time. If not, you want to give it. I think some people are still doing it. It has a protocol to be given. I can say but it's a problem. You know, it can be not easy.
Okay, Professor Dr. Mahmoud.
Second question, with rituximab treatment, do you follow CD19 or serum IgG levels, and when to give IVIG with lower IgG level?
Okay. For Rituxan, some clinician doing immune globulin, especially IgM, and if his IgM went down, they give IVIG 1 dose. I don't do that. You know, very rarely, unless I see some signs of infection. There is the standard of care. It depends on the infection itself. It's not mandated to be done to everyone. If it's somebody, you give Rituxan, it's a great drug actually, and we don't see much of this thing. But if somebody develop infections and stuff, at that time you have to worry about it. So some people do even CD19 level, and I find that Rituxan can wipe CD19 for a long time. We did that during COVID. We checked people on Rituxan. CD19, we found it 0 almost after 6 months or a year of giving Rituxan. So it depends, actually. There is no recommendation for every Rituxan dose you give IVIG. There is no big recommendation. You can do the measurement, and doesn't mean that's low, you give it. So once patient develop recurrent infection, sinusitis, UTI, stuff like that, you can look to it and you give it IVIG, depend on the CD19 and IgM low. But if it's not a standard of care to do it for every patient, it's very costly for you guys and for us too. So basically, and a lot of clinicians don't do it routinely. We just give Rituxan for patient. If anything happening, I may look to it.
Okay, second question from Dr. Abdul Hamid. In a vasculitis patient starting dialysis with dialysis dependent, when and how to withdraw medications?
Withdraw medications, as I said, 2 years after good remission. So you maintain remission, like patient maintenance dose, lower dose, whatever, Imuran, 50 milligram, whatever. If you don't have much of, you cannot give methotrexate in dialysis patient, can cause severe bone marrow depression. You cannot give, like, so the best, even mycophenolate or Imuran, I'll think Imuran will be the best for this maintenance from dialysis. And you can, like, basically watching over. If patient continue to be in remission for long time, good time, be sure there is nothing else other than kidney, like lung, no any neurological things, nothing. I will be withdrawing the drug after like sometimes. But prednisone and Imuran can be good maintenance until at least they said 2 years after complete remission, last attack. But if patient does not have much of problem, maybe a few time and I stop it later on. But I keep 50 milligram Imuran for longer time to be sure that we don't get any problem.
Professor Amr, if you don't mind, Dr. Mahmoud, Professor Amr, you can tell your question, please.
It's just a concern because I see in Egypt a lot of children are getting levamisole either as antiparasitic treatment or in the use of steroid-resistant or steroid-dependent nephrotic syndrome. And I see it has been associated with ANCA positivity. Can you please comment on this, Dr. Sami? I mean, in America, it's a different story because they mix the heroin,
Mix it with cocaine.
the levamisole. But I hope that this is not the case in Egypt. But please comment on that.
100% right. I have a patient cocaine-induced vasculitis, and I saw this patient. They bring me in the hospital after they give pulse steroid and all these things. And patient, I came to the hospital. I found that she has nasal perforation, typical ANCA, and ANCA positive, C ANCA positive. Even PR3 was positive. And then basically no one knows that she's in cocaine. No one did the cocaine level and stuff. The reason for cocaine induced because of levamisole combined. Most of cocaine now is not a pure cocaine. It's usually the added to it. And I was in kind of work I was in Bolivia recently, and Bolivia is a big country of cocaine. And basically and I found that huge, I was seeing patient there. I was doing I was given lecture, big rheumatology meeting for lectures there in South America. And I found that, and they told me, and from people there, usually because they do it on a high level, high altitude, this high altitude there. And then they grow cocaine there. The actual cocaine that growing is not a common things you find now. Most of stuff coming now, synthetical cocaine, is not a typical cocaine that grow on this. And even they treat most of diseases with cocaine tea, coca tea, and this is what they do. But they told me the cocaine that's now available is not the typical cocaine. It's all mixed like with levamisole, and that's what is so. So levamisole is the key of vasculitis. This is the key of not the cocaine, it's levamisole. So this patient, what I definitely, when I saw her and we did blood level, we find cocaine in the blood and then urine stuff. And then it's not involved with much of kidney, but she has typical lung involvement, nasal involvement, a lot of other things, typical vasculitis. So it almost they're gonna give her cytoxin. So we did a specific C ANCA level specific. There is some, like you can do certain tests in C ANCA specific under, and we found that positive. And this is, and plus the cocaine positive. So this is cocaine or levamisole induced vasculitis. And watch out that, because levamisole, one of the drug, can cause that. Yes, you're right.
تجار
Okay,
المخدرات
our last
خلاص ما عادش عندهم ضمير.
طبعا حتى يغشوا بجد يعني والله هيخشوا النار كده.
فين أيام الإدمان الجميل.
حتى ده رقم
But in Egypt, but in Egypt, it might be a different story because levamisole, they are using it a lot as a therapeutic agent. So
yes, that's true.
I just put in the chat box that 18%, this study was published this year in pediatric nephrology, 18% of children who received levamisole for steroid-dependent or frequent relapse nephrotic syndrome have ANCA-associated vasculitis. 89% of them with B ANCA and a small fraction with C ANCA, and I think there is about 8% combination of both C and B ANCA. And I think also one of the key about drug-induced ANCA-associated vasculitis is it's not only B or C, it's usually associated with might be multiple autoantibodies. So when you see multiple autoantibody positivity, you usually think about presence of drug-induced ANCA-associated vasculitis.
This is perfect, right? But the problem also skin. They do necrotic skin. This is ugly. I have patients severe eating all the legs, bad necrosis, and it's mainly. And you do biopsy, it shows actually, like it shows that leukocytoclastic vasculitis, typical vasculitis in the skin. So it can be misled easy unless a patient denied to take cocaine or patient on this in Egypt levamisole is he taking it. But generally, it is skin is the key. Skin and nasal is the two problem we can see with this cocaine induced.
Absolutely. Thank you.
Okay, our last question on chat, asking about biomarkers like CD163 and NET, neutrophil extracellular traps in diagnosis and pathogenesis of vasculitis.
Biomarker of what? I'm sorry?
CD163 and neutrophil extracellular traps. Theoretical biomarkers, I think.
I actually am not familiar of that, and these biomarkers, I'm not familiar with it. I don't know if anyone knows it. Let them know. But you know, there is a lot of they now actually they are all in advances in lupus nephritis. They are developing something now, biomarkers to look to that and to diagnose it without kidney biopsy. Maybe there is some advances in biomarkers, huge advances in biomarkers. Maybe one day we have that without getting to do the biopsy anything. But I'm not familiar with it.
Okay.
Any more question on the chat, Dr. Mahmoud?
لا كده we stop, no other questions.
Okay, I don't know Professor Hisham is with us or not. Maybe he's a bit tired. Okay, now once again I really thanks million Professor Sami for this great night and great presentation and very fruitful discussion from our professor and very comprehensive answer from your side. So once again, we were honored to have you with us tonight, and we wish you to be again and again and